All right, so can everybody see my screen okay? Yeah, okay. Um, I want to thank everybody for joining today, our interested party engagement session. This session will focus on rehabilitative services under Section Policy 102. So, as I said, our focus today is on activities and codes related to those rehabilitative services as defined on the slide, which specifically fall under Section 102. So rehabilitative services are those covered services provided under the direction of a neuropsychologist or physician and delivered by a neuropsychologist, physician, occupational therapist, physical therapist, registered nurse, speech language pathologist, or other qualified staff meeting the qualifications identified in Section 102.08-5. And just kind of level setting here with that definition and identifying that for everybody on the call. So as we start talking through the questions and maybe that answer section and looking at the codes, that is specifically what this is focused on. I say that because this is actually our last and final initial kind of focus group that we've had. Um, Trying to gather some general information. So wanted to kind of identify that again of what we're talking about when we look at those questions. I also know that rehabilitative services sometimes are, some of the codes can fall under other sections, but we just lumped them all together today for this. So rehabilitative services codes, the current ones are identified here. With the assistance of main care, we're displaying those here on the slide. There's a total of 13 with all the modifiers of this section of policy. And I will display the next one as well. So these are the codes that we'll be talking about when we're talking about the questions and what potentially you may have, questions or challenges or things you wanted to identify. So these are the particular codes. So for our agenda during the next 60 minutes, we'll quickly review the rate determination process, project overview, goals, and activities, and then get into the questions and opportunities for discussion and feedback. So next, for introductions, I'll introduce the PCG or Public Consulting team on the call. Myself, I'm Rhonda Kern-Strelzer. I'm a Senior Advisor of Behavioral Health and the lead for interested parties sessions here with this project. Some of you I may have talked to or been involved with another project in the state of Maine. So thank you guys for joining as well. And happy to see you again. Some of the other members on our team, Emma Finestone, she's a project lead and senior consultant. Maddie Wall's a business analyst. I think Caitlin Crone is on the call as well. She's a senior consultant, as well as Jonathan Sauershow. He's a senior consultant with us. We do have some of the main care team on the call today. So I'll go ahead and turn it over to Kristen to start the introductions there.
Thanks, Rhonda. Hi, everyone. Good morning. My name is Kristen Merrill. I'm a Senior Policy Manager with the Office of Main Care Services in the Policy Unit. I'm joined by my colleague, Tom Leet, today, who is a manager within our Policy Unit as well, specifically for long-term services and supports and waiver programs. Again, just want to thank everybody for joining. We're really looking forward to your feedback today. And if folks that are attending today could also just introduce yourself in the chat, just for record keeping purposes, just your name and your organization, that would be super helpful. With that, I'm going to pass it over to Dwayne.
Morning, everyone. I'm Dwayne Parsons. I'm the rate setting manager for the Office of Main Care Services. I'm joined by Jessica Levesque, rate reform analyst, Jennifer Morris, our HCBS project manager, and Amanda Lee, our rate setting coordinator. And I will pass it over to Derek Fales.
Thank you, Dwayne. Derek Fales with Office of Aging and Disability Services. I oversee the day-to-day operations for our home community services for brain injury, individuals with intellectual disability, other related conditions, and oversee the brain injury rehab services. And I'm joined by my colleague, Dina Blanchard O'Geary. Thanks.
Is there anybody else on the call, Kristen, that we've missed, or Dwayne?
I don't think so.
Okay. All right. We will go to the next slide then. This is the rate determination process, just kind of a quick overview here. While this meeting is focused on feedback from participants regarding rehabilitative services, I do want to highlight the process from a few slides on the kickoff call, which was held at the end of August. The rate reform process does set schedules for regular rate reviews, benchmarking, creates a transparent process, and includes technical advisory and comments. So this is just kind of highlighting that on this slide. So the steps for the rate determination process include a kickoff call, which again, like I said, was held back in August, and it was actually August 28th. That can be found on the rate reform website, and someone will put in the chat the link to the rate reform website, so you can go there and look at it if you want to as a quick and easy access. It also includes public forums for feedback, which is, again, this is our first ones. Official written comment period, which has not opened yet, but once it does, you will be notified and have an opportunity to do that. And then we will also do like a final rate determination out of the whole project, which should be done around April of 2025. So during this process, PCG will hold and conduct interested party sessions. We'll collect data, we'll complete analysis, we'll develop rate models, we'll draft rates, we'll make presentations for comments, we'll finalize those rates and publish them, and then for the department to make a final recommendation for consideration for rule proposal and adoption. Also, I want to review a few items from an interested parties engagement standpoint. As I said, these meetings are the first kind of general meetings to start gathering information, and we anticipate further meetings in the future with additional focus items, as well as a survey to gather more feedback from providers and interested parties, stakeholders, whoever it may be. So in addition, we also have an email set up that you are welcome to send information, questions, or comments to. And that email should be coming out in the chat shortly. We'll also have it displayed at the end as well. And please feel free to reach out to that email box anytime during this presentation or after, whichever, throughout the duration of this project. So for the project overview, following the established requirements for the rate reform process, this project that we currently are in and talking about focuses on home and community-based services, including assistive technology, devices and services, care coordination, clinical services, clinical therapy services, supportive skill building, therapeutic interventions, personal support services, and then rehabilitative services, which today's meeting specifically is focused on under section policy 102. However, all of these sections together, like I said, is kind of that entire focus. And then for rehabilitative services, I do want to note that we just kind of pulled across all of the different types of services, all the codes that, kind of fall under section 0102, and pulled you guys into a group as well. I also want to note that there are other projects occurring simultaneously with other partners in main care during the same time frame, which are reviewing other sections, payments, rates, codes, things like that. So if you're not seeing a section listed here, please check with the rate reform website for other projects ongoing. Again, the section meeting will focus on rehabilitative services. However, if you're interested in providing other feedback, please reach out to us via email, or certainly look for the upcoming meetings or other opportunities such as the survey that will be shared out via the the listserv. So all communication will go out through that listserv for any other future projects as well. And I think we will be putting that link as well in the chat. If you're not on the eServe notification, that way you can sign up as well. So our project goals, from our standpoint, we need to develop and document appropriate benchmarking, service definitions, rates, and coding alignment, encourage and engage closely with interested parties throughout the whole project lifecycle, demonstrate the impact of changes to rates and service definitions, ensure alignment to state and federal reimbursement requirements. And so for the project activities kind of overview and what we've been doing to date, besides interested party engagement sessions, we currently have identified the codes and rates for each section, and the list can be found on the rate reform link. We will also put it in the chat. I think there is a link that you will get as well in that chat that you can go directly to the code listing. We've also been analyzing codes, identifying benchmarks up to this point. And then for any of those services without benchmarks, we're creating benchmarks with input from providers, certainly creating assumptions based on best practices and national trends and other things like that. So again, that's why throughout the project, we want and will have other engagement sessions with interested parties to get additional information and help us identify some of those things as we continue through the process. So with that being said, we're going to start on our first questions. Please feel free, raise your hand, you can come off mute and, ask questions, provide comments, anything like that. You can also use the chat as well. So you can, identify or make a comment. If you don't want to talk, that's fine. You can also send something to email, after this session as well. But certainly we encourage and want to hear from you. I know the session we had 2 days ago was great. We heard a lot of information and, some challenges and, different things that were impacting those providers as well. And so it's really a great opportunity for you guys to, let us know of things that we need to be aware of as we continue through this rate determination process, because we want to hear that feedback and it will help develop the rate model and structure in the future. So the other thing that we'll do is we'll pop up with the codes as well on some of the questions. So then you can see those too. So with that being said, we'll go ahead with our first question. What concerns do you have about this rate determination process that you would like the team to be aware of regarding rehabilitative services?
Hi, this is Scott Mayo with Maine Center for Integrated Rehab and Rehab Without Walls.
Hi, Scott.
Hey, back in 2020, we had some changes to definitions and the codes, and it was implemented prior to, I'd say, all 102 providers knowing there were being changes. What I know you said the timeline here is to have a final kind of product out by April 2025. Are we looking at, I'm sure the state will review that. What will the rollout look like with these changes, and what's the time frame, the announcement, that the education going to look like post the end of, or post April decision making?
Sure. So I can answer kind of up to that point. So like I said, as we go through this, we will develop that final report. We will then turn that over eventually, and certainly work with the state throughout this entire project. We'll then turn that over to them, like I said, around that April 2025 with final recommendations. And I'll turn it over to the main team to kind of discuss, from that point, what they will do.
Yeah, I'll take that. Thanks for the question, Scott. We don't have a definitive timeline yet for implementation of the recommendations coming out of this determination. So it's one of those things where we really can't provide an explicit timeline, unfortunately. But the steps that will occur, as part of implementation, obviously would include provider notifications, potential rulemaking, so messaging via e-blast, e-messaging, updating of fee schedules, things of that nature that typically coincide with changes in reimbursement or reimbursement structures.
So would it be safe to say, Kristen, that as like April 25 is not going to be implemented immediately?
Yes, that
Okay.
is safe to say. Implementation
Okay.
will not be April.
Okay.
Right, thank you.
Other concerns or questions or anything that you might have regarding the rate determination process that you would like to ask, or, see if you can get an answer to, or just make us aware of anything.
Hi, I have a comment. This is
Sure.
Jen Jello.
Hi, Jen.
Hi, nice to see you again.
Nice to see you.
This is probably something you're already aware of. I believe in Maine, I think everybody's aware there's sort of a workforce shortage, and it's not just direct care workers, it's professional therapy staff as well. And there's certain therapies that I think are more impacted than others, like speech therapy feels like a very rare commodity these days. Um, I think just for a point of awareness, one of my concerns is that the rates reflect a wage component that's realistic for the environment in Maine. I recently saw a report for neurobehavioral treatment services that did some analysis about wages, including professional therapy staff. And what I'm paying my staff was so above what the averages were listed in that report. So I don't know if others are feeling this as well, but I want to make sure that we're able to have a rate that we can hire competitively, that we can retain our professional therapy staff in a rate that covers that in a reasonable way.
Sure. Absolutely hear that, and something that we, has been echoed as well. So we will absolutely take note of that. And just to also let people on the call know, one of the things for PCG, we look at a whole host of different pieces and parts as we're starting to look into the rate and what goes into that. So it may be, travel. We heard yesterday or a couple days ago about, specific rules related to Maine, with overtime or emergencies or, different items or pieces like that, as well as workforce wages. So we will look at some of those different pieces as we go through this. Thank you. Are there other things or anything else anybody would like to bring up about this rate determination process? If not, we'll go to the next question. However, if we need to go back to a question or maybe another question kind of prompts some thinking, we can please just raise your hand. We'll go ahead and address that or go back to the question as well. So don't worry if we go past it and you're like, wait a minute, I need to say something. So the next question is, are there specific codes or rates for this rate determination process where you think changes need to occur for rehabilitative services and why? And Jen, you kind of already just noted, in general, speech pathologists, for an example, or some of the other therapeutic type services are the wage, it doesn't sound like is meeting what the reimbursement is, and it's creating challenges of recruiting. So I will also, we can note that, but I will also go back to the codes, and I apologize because I have to flip back. But if anybody has anything else, please raise your hand or put something in the chat, come off mute. We'd love to hear it.
I do have one suggestion, and I don't know if other 102 providers encounter this. A number of years back, there was a change made to 102 where there's the use of encounter codes. And then for each 15 or 30-minute unit, there's like a follow-up code. And the implementation of encounter codes was very, very challenging. One, because many of us use like a scheduling software. So having an encounter code that was one measure of time, like 15 or 30 minutes, and then a follow-up code that's a different measure of time, um, was, we had to make changes that were costly within our scheduling software. But then too, we found it was limiting our ability to provide services to participants. So just as a theoretical example, let's say someone comes to the outpatient clinic and they have a physical therapy appointment, and they have maybe they don't make it through the whole appointment because they get a migraine. And so we reschedule them later in the week. If we hadn't budgeted enough encounter codes, because maybe they come less frequently, maybe they only come 3 times a week, you have to have an encounter code in order to have a follow-up code. And if that was used earlier in the week and the person didn't get a complete session, they're kind of out of luck. So we have to be very strategic about our authorizations and how many encounter codes we're requesting for a week of service. And it was just simpler the old way, where if you're coming for physical therapy, you're using an intensive code, or if you're coming for maybe a less skilled group therapy. I don't know if I'm explaining it well, but the use of encounters and follow-ups added some unnecessary complexity, and maybe there was a reason for that implementation that I'm not aware of. But if there was a change, I'd like to see encounter codes eliminated.
And Jen, can you explain what the old way was? Was it just essentially you got a set of codes? Do you remember what that looked like?
If memory serves, I was around at that point, and I know there are others on the call that I think have been around a long time too. I heard Scott speaking, but there was a set of codes. So like if you were a physical therapist offering a skilled therapy, you would use a code like 96129 or 96130 or something similar to that. And if you it was just 15-minute units. So if you treated somebody for 30 minutes, it was 2 units of that code. If you treated somebody for an entire hour, it was 4 units of that code. And all the codes were the same measure of time, like 15-minute units. And there was some simplicity with that.
Yeah,
I
I
just,
can I can
go
speak a
ahead.
little bit about it, Rhonda. The change was actually it was a direct result of national coding changes. So at a national level, they revamped the definitions for the codes that were in existence, and then also combined or deleted or created some new codes to represent these services in the way that Jen was just describing. So it was the implementation from the department side was really complying with what was happening at that national coding level. It would be interesting though, Jen, if you had suggestions or anybody on the call have suggestions on alternative coding that exists that would meet the needs of your population, the services you deliver, and what you're suggesting in terms of timing allowances or codes that specify time.
Yeah.
And that's not something you need to articulate or anybody needs to articulate today, but if you have that information and could send it to us in writing through that mailbox, that would be helpful.
Yeah. Yeah. And I wasn't sure, like if previously, and as Kristen had mentioned, that kind of methodology and some of those changes, makes sense, but I wasn't sure if there was like a previous methodology, like a per member per month or something like that, that was different back then. So that would be very helpful. And Jen, if you would please reach out if you have any ideas with that, that would be great. Or anybody else, like Kristen had mentioned. So anything with the codes listed here, I'm going to go to the next slide as well. Anything else regarding specific codes and potential changes and why? Okay. If there's not, we can go to the next question. But like I said, if we need to come back, we certainly can. And again, I apologize for having to flip through my screen. So. So the next question, are there gaps in existing payment methodologies for this rate determination process to highlight for the team for rehabilitative services?
I hope I'm not going to be the only one talking. I don't know if this comment attends exactly to this question, but in the outpatient clinic, so there's sort of a best practice in the world of rehab of, um, let's say, and we know that people with brain injury have a lot of medical complexities sometimes, and it's not unusual for someone to, have a brief stay in a hospital, or they've had some kind of change in status, so they go to a skilled facility for a little while, then they discharge back in the community, and they need some rehab to sort of get back on track with their mobility or their cognitive functioning or something else. Brain injury is not like a straight line, right? It's all over the place. Um, One of the things that's challenging is in a lot of facilities, their best practices. So if somebody's discharged for more than 3 days, or if they've had like a lengthy stay in a hospital, um, our intensive therapists, a physical therapist, an occupational therapist, they want to reassess because there's been some kind of change of status, right?
Mhm.
So there's some limitations to the assessment codes. So I'm trying to remember, what is it? It's like 16 units or something for a certain amount of time. And for most people, I think that probably covers it. You assess upon admission. You might assess one other time if there's some kind of unique situation or change of status. But for people that have medical complexities, and they might have a couple of hospital stays during the course of a year, or there aren't enough assessment codes to reassess. So the therapists are in this awkward position. Do we sort of reassess sort of during a treatment session and sort of bill it otherwise, or so we might want to put some thought about what the caps are in that for those types of situations. And I'm not saying that necessarily needs to mean that you increase caps on all the codes, but I did find that limiting.
We have actually, sorry, I'm also getting different pop-up messages and things like that. So if I seem distracted at times, I apologize. But I will say, yes, we have heard that earlier in some other sessions as well about, as well as I think for the other project that we're also doing about those assessment codes and that time frame and the follow-up code. And how to use that and that total time frame. So thank you for identifying that and bring that to our attention for this session as well, and how that is also a gap or kind of an issue with the current payment methodologies and with the individuals you guys serve. Anything else that anybody would like to add on to this particular question, or maybe what Jen had already identified? Jen, I see you're off mute. Do you want to add some other things? Go ahead.
I have one other minor one, and I don't know if I would identify this as a service gap, but it's certainly a challenge for main care members in getting services. So when there are people, whether it's a community member or whether they're residing in a waiver home, there are occasions where there's some type of in-home skilled nursing needed. It might be wound care. It could be, they've had some kind of procedure and there's like visiting nurses or something that's coming in for a short stint. And we sometimes find that um, those agencies that provide that in-home care for wounds or for in visiting nurses, if 102 is an existing service, they won't come in and treat, or they don't want to bill simultaneously. They don't want to have any kind of duplication of service. And in truth, I don't think the 102 clinics are probably providing wound care. So if there was some type of revision in the regulations that we don't want to see a duplication of service either, right? We want people to be able to come for their rehab therapies and get better. But if there is some kind of, other ailment that we are not treating that would be appropriate for visiting nurses, we would like a patient to get treatment simultaneously and not have to discharge from 102 in order to attend to their wounds. I don't know if I'm making sense, but so I don't know if that's exactly a service gap, but it's a problem for care. And that might be a nice thing to refine a little bit in the rulemaking process.
So I certainly hear you, and that's something I think we could note. While this is not for per se the rulemaking, it is more along the lines of that payment. But I certainly hear it's really hard to tease those two things out because those kind of the rules and payment kind of go hand in hand. So we will certainly make notes of those things, Jen. Also, what I did hear you say is, essentially someone's in a 102 clinic, they have wound care, for an example, they have to be discharged from the 102 clinic to receive the other care like wound care is what I'm hearing, which then causes a gap in their overall health care as well, because they're stopping one type of care to receive another. Is that what I'm hearing? Okay. Okay. Perfect. Thank you. Anybody else want to add anything regarding gaps in existing payment methodologies or challenges or anything else? Or add on to what Jen was saying? Okay, it looks like we do have a comment from somebody. Michelle had identified that those were nice points, Jen, and certainly they agree. So thank you, Michelle, for providing that comment and feedback as well. We will go ahead and go on to the next question. Like I said, if we need to go back, not a problem. Emma has also, I see in the chat, put in the email for this project. So please feel free to reach out there if need be as well. So next question, what do you think is most valuable for our team to know regarding rehabilitative services for this rate determination process? And I can give a couple of examples. So one of the things is in one of the sessions previously, it was like, we want you to know case management and care coordination are two separate different types of services. We also have heard in one of the other sessions that, geography plays a major role in, our staff, like transportation, for an example, or parking, or, some things like that. So it can be care related or how the service is delivered, or something that you feel that's really important that we need to understand as we're looking at the rates to help make some determinations and looking at creating those rates in that rate model.
Yeah, this is Scott again. I think it's important to understand the brain injury rehab model and understanding how group therapy is so beneficial to folks post brain injury, the community reentry aspects that a diverse team, a very comprehensive, integrated transdisciplinary team can provide, working in the clinic or out in the community, as well. So addressing some really high level skills, related to getting back into the community and helping these folks access, um, what they want to do in their communities of choice, whether that be the things that are out of necessity, and also, from a recreational or leisure perspective, to actually add some quality of life back to their lives after a brain injury. So the importance of those types of programs and access to community and the benefits of group therapy.
Absolutely, Scott. Thank you for bringing that up and identifying, you know, brain injury as a model, and the importance of that multiple disciplinary team approach, as well as all the different types of services that are available, such as group. Other things that anybody would like to identify um, regarding rehabilitative services that you guys feel that's really important? Like I said, it could be geography related, it can be transportation, it can be service delivery related, pretty much anything, or like Scott mentioned, and how, you know, the certain components in the delivery of care are very important. Um, One thing I would like to ask, I was in Maine last week and actually visited some facilities, and I heard staffing as a challenge. Is that play into the rates models? I know, Jen, you kind of already mentioned a little bit about the therapeutic providers, but what about some of those with the direct service providers? Scott, I think you're off mute if you want to go ahead.
Yeah, recruitment is definitely a challenge. And also, just the demands or the requests of new staff coming on is increased dramatically over the last 4 years per se. Definitely from COVID to now, we've seen a huge, increase in salary requests. But in general, just the pool of applicants and candidates that are qualified to work with this special population, is not very large to begin with. So, that's very hard to get folks that really want to work in the brain injury field. So, um, it's a very small pool of candidates to start with, and then when you get into such a fine specialty like this, it's even, the pool gets even smaller and smaller. So, the available candidates is limited. The rate increases have just jumped through the roof. Thank God over the last couple of years, there have been built-in cost of living increases because salaries are just crazy right now. So,
Okay, thank you for elaborating some more on that as well, Scott. Um, Definitely, I feel that that's important for our team to also hear and know as we continue through this rate determination process that, some of the salaries have went up and quite a bit, it sounds like.
well, and your recruitment costs too, just to find people. You've got to get outside of the state of Maine a lot of times, for most disciplines. I'd say probably the only one we don't really look outside of the state for is like rehab tech. But if you're looking for licensed clinicians, you better cast a big net, and it's outside of the state, it's outside of the region, it's national, and there's a lot of recruitment dollars that are spent trying to find the right people.
Okay, certainly hear that as well. Something that we will absolutely note. I see. Looks like there's some individuals agreeing. Is there anybody else that would like to add anything to that discussion or conversation with Scott? I also see, Jen, you have posted something in the chat as well, and I'll go ahead and read that. It says, I really appreciate that Maine offers integrated services for a long period of time. Commercial entrances sometimes cap at 12 visits, which is not long enough for real recovery. This is something Maine does well, and I hope this benefit continues to members. Is there anything else that you would like to add, Jen, to that, or anybody else on the call?
Just 100% agreement.
Okay. All right. Thanks, Scott. Okay. Anything else before we go to the next question? No, we have about 16 minutes left and certainly want to get to the next question. If there's nothing else. And even if there is, we can come back. So the last question is there any additional information regarding rehabilitative service delivery, payments, codes that you would like to share with our team?
Hi, this is Corinne from Maine Center for Integrated Rehab in the Brewer office. I guess I just wanted to jump on previous comment that was made about sometimes the struggle with, I guess I can't remember who spoke, but she called them encounter codes. But you know, we have patients that are here, maybe scheduled for a full 18 hours a week, and maybe they still have, you know, one skilled therapy with PT, let's say, and the PT is out sick that day. And that 1 hour of code that we have to have for that one particular service now is a lost hour for us because no one else can pick up on that code and we can't revert it to or convert it to a group code. So we're kind of locked in. You know, and sometimes it does make it really frustrating for the patient and frustrating for us and as the schedulers. So I feel like that's one of the biggest frustrations with those codes. They do kind of tend to really lock us into, you know, less flexibility.
Absolutely. And like I said, we have definitely heard that in some previous sessions as well. So I'm glad you guys are echoing that as well. So that's a great opportunity for our team to kind of look at some of those things, or, you know, certainly to let the main team hear that as well, if that's not fully in the scope of this project. But we have glad that you spoke up with that and certainly added to that conversation, Crane.
I just think related to this question as well, the accreditation through CARF is a huge piece that all our 102 providers have to do. We are doing, and I think that's something that needs to be considered as far as, you know, not only the resources that go into it, but what comes out of that related to quality and outcomes in health and safety. So something definitely that is a big part of what we do on a daily basis.
So, Scott, can I ask this question further? You know, accreditation, and this is something I know I've heard in this project as well as a lot more in the other project. Um, and thinking about payments, you know, accreditation's not is not cheap, so to speak,
No,
right?
no.
So would you want to kind of talk with us about this a little bit, so we can make sure we've got it noted and our team is aware?
Sure, absolutely. It goes beyond, you know, your application fee to CARF and the potentially tens of thousands of dollars just the application will cost you. It is all the time, energy, and effort. And I can speak for our organization where we're not very heavy administratively. So your clinical teams are involved in a lot of the standards that aren't just related to the clinical components, the health and safety pieces, just every little detail right down to IT, and what that takes on a daily basis between, you have things that need to be done on daily basis, weekly basis, monthly basis, quarterly basis, semi-annual, annual basis, tracking data, reviewing data, implementing performance improvement plans around the data, constantly evaluating that plan and making adjustments on the fly. So there's a lot of engagement with the team outside of their clinical time, quote unquote, on the floor working with patients. So it's a heavy demand. So I would say that the tens of thousands of dollars for the application is just the tip of the iceberg as far as the financial piece, but the time, energy spent on just making sure you're living those standards and you have a great result with your survey. It's a massive undertaking that you're just constantly ingrained in, right? And you don't a survey doesn't show the work you did over the 3 days. With CARF, it shows the work you've done over 3 years. So you can't only prepare for a CARF survey for 6 months. It's every day. So it's a huge commitment. I value CARF. I think it does have value in this program, but it takes a lot of time and energy to meet those demands.
Thank you for talking through that a little bit more, and the costs kind of associated with it, whether that's like you said, the application cost or the resource cost, right? Like throughout the whole time, and until CARF comes back around to survey you again. So thank you very much for identifying that as well. I think that's important for this service. Jen, I see you come off mute. Go ahead.
100% agree with everything Scott just said. He's spot on, and I think we all sort of experienced that. Scott touched on the administrative burden on clinical staff, and I wanted to just expand on that a little bit. I think it's important that the rates consider that, right? Where it's not just the treatment time. That any single therapy staff is probably doing some kind of session note, right? So that there's, in the event of an audit, we can, prove that a service was provided between 9 a.m. and 10 a.m. There are progress notes, documentation that are part of the rule. So there's some administrative need that's not treatment time that's associated with progress notes. There are monthly meetings, with the patients for every single patient. There's clinical conversations. So I think, and then there's more than that with all of the quality things that Scott just mentioned that we do for health and safety and education, and working with families to make sure that skills are transferable. So I think it's important that the administrative component to our clinical team is captured as part of that rate, because it is pretty heavy.
Certainly hear you on that, and thank you for identifying that as well, and highlighting that. I will say that's one of the things we do look at for our rate. We look at that administrative. Another valuable thing I will tell everybody on the call, we are going to be sending out a survey to providers. Highly recommend and encourage everybody to complete it, because one of the questions related to that will be around, how much percentage of time someone is spending doing XYZ. So if you could give us some highlights there, I think that would be very valuable for our team to take forward into this rate determination process. And we certainly want to hear that, so we can capture some of those things in here. And then I see Michelle has commented in the chat. Absolutely agree with Scott. CARF adds an administrative burden that is really not funded and is difficult to do within existing teams, as it takes a lot of time not related to any direct care. Anything else, Michelle, you'd like to add to that?
No, I think that's it. I don't do the 101 neuro rehab, but we've spoken before, you and I, as it relates to the residential. Okay. And that's why I can agree on the CARF requirements of just adding a burden, I think, to any one of our modalities that are being offered under these services. So it is something that really needs a lot of consideration. I appreciate that you're going to be doing a survey with asking for that information.
Yes, we will be. And like I said, that should be coming out relatively in short order. So please watch for the listserv. Also, I would say encourage others that you know that maybe are not on the listserv, or maybe, you know, other administrative staff, or, you know, someone on your staff that may have some more insight into some of those questions. Ask them to take it. You know, I feel like we can take that information on our team side, you know, and really kind of digest that, pull it together, and try to look at how it's impacting out there in the real world, right? And that's really what we were wanting to do with that information, as well as having these engagement sessions, really talk with you guys and get information from you guys that will help inform us to do the rate determination and continue through this process. So, anything else anybody would like to add related to this question, or any of the comments that's been made, or anything, any of the other questions?
Can I just throw this out there?
Sure,
Trans
absolutely.
transportation.
Yes.
On my calculations, we're probably looking at, based on vendor or transportation companies only canceling, like they are the reason why a trip to or from the clinic is not happening. We're on track right now for about $160,000 lost in revenue between my 3 locations. So transportation is a huge component to access, which obviously limits the amount of, or the consistency of a patient's therapy, but it also has a big business component to it. And, you know, we're talking 6 figures of an issue here. I've had roughly at 80,000 through July. So, and we know a lot of times that's winter and things like that, but we kind of exclude that. That's just
You account for that.
vendor calling up and saying, we can't do it today. Or, you know, we can get them in, but we can't get them home. So they cancel for the whole day. So just reasons from their end only. That's what that level dollar amount is.
Thank you for providing that to us as well, and identifying, you know, that transportation, which I have heard multiple
Yeah,
times, but
I'm
this is a
sure.
new kind of a twist to it. So, thank you for identifying that, looking at it from a financial perspective, as well as the care and quality perspective too, for the individual receiving care. And
Exactly.
they can't get there. So, and there's a financial impact as well. So, okay. Perfect. Jen, were you off mute? Do you want to? Nope, you good? All right. Anything else? And anybody would like to add to the discussion? We have about 4 minutes left, so we'll wrap it up. But if there's anything anybody else wants to put in the chat quickly, or come off mute quickly about, we can take that time. All right, with that, I will go to the next slide. Well, here's our dedicated project email. So main HCBSC and N at pcgus.com. And that is for this particular project for the HCBS rate model determination process. Some of you, I've spoken with you as well. There is another email box for that other project. And then you guys also, some of you have my personal email. So, you know, even if you send it to the wrong email inbox, it's okay. It's all going to come to me. So just to let you guys know that as well. For some of you that I've worked with on the other side. But either way, we'll get it. And then I will respond back to you as well. So if you want to send a comment, a question, you know, something else that's popped up in your mind, or maybe something that you're thinking about that might be related to payment and service delivery in this aspect, or even if it's something else, you know, I will try to get it addressed for you, or send it along to the right people, or help you get to the right people to get your question answered. So with that being said, I I do appreciate everybody attending. Thank you for all your feedback and your comments, questions, any of those things also to help us understand. Please look out for that email listserv invite or link that you'll be getting for the survey once it comes out. And it should be, I would say, in the next couple of weeks, maybe 3 weeks, something like that, depending. We're still working on the final pieces between our team and the main team, but it will be coming. Just start looking for it. And please take it. And then if there's nothing else from the team or from anybody that's attending today, we will give everybody a couple minutes back, finish on time. But otherwise, thank you guys as well for, like I said, attending and providing a lot of different feedback for us. And hopefully we'll talk sometime in the future in one capacity or the other. So, all right. Take care, everyone. Bye-bye.
Thank you.
Bye-bye.